Are you?
I'm good. How are you doing?
I'm doing well, thank you. Can you please tell our listeners a little bit about yourself?
Sure. So my name is Dr. Rachel Ferraro. I am a current HIMSS AME in Coeur d'Alene, Idaho. Um, I have been doing AME work for almost 2 years now. Prior to that, I was or am a board certified internal medicine doctor who primarily worked in the hospital. I've worked in a couple different states. Idaho's my favorite. And I'm also board certified in obesity medicine and wellness.
Awesome. We have had a lot of conversations prior to this, and you have so much information that our listeners are going to be interested to hear because what you and I want to focus on is aviation medicals as it pertains to women
Right.
and women specific just things to think about, women's specific issues, medications. So, why don't you give the listeners a little bit of a brief synopsis of what information you want to get out there?
Yeah, so I should also mention I am a 99s member and a student pilot. And I actually write a recurring article in the 99s magazine, which, if you don't have a subscription, you can actually view it online. And it's called Ask the AME. And so some of the topics I think we're going to touch on today, like the female flight physical, are actually in the magazine. I started writing for them in January of 2025. So the magazine comes out every 2 months. There are women specific articles, there are general medical articles. So a good read, you can access them online. And I just thought I would put that out there.
Yeah, that's
Yes.
helpful.
So, yeah, so I think one of the first things we wanted to talk about today was sort of as a woman, how to prepare for your flight physical. The majority of AMEs out there are male. Female AMEs are a minority currently. That may change, but currently they are. So, a lot of women out there do have male AMEs. And sometimes it can be cumbersome to know or to not feel exposed when you are going to see any provider, right? And this kind of goes for any of your doctor visits because your primary care could be a man, or maybe it doesn't matter if it's a male or a female provider. You just want to be comfortable. And so I think starting by talking about some tricks when you do go to your AME visit, that can make things a little bit more comfortable. We can touch on. And then I think you had some questions from listeners that we were going to kind of go through and then just see where it takes us.
That sounds good. Yes, you had some very good tips and tricks for how to have the best aviation medical experience as a woman. So, yeah, let's get started with that.
Okay. So I would say it kind of depends on what is going to happen in the medical, meaning that if you are going to need an EKG or not. So we'll kind of talk about that. But every medical requires a urinalysis. And so one of the first things I say is when you're coming into the medical, I personally think don't wear an underwire bra. And that's more so because of the EKG. I say wear a sports bra with maybe a button up shirt, and we'll get to why. And then the urinalysis happens on every flight physical. And one of the things that I think some people don't think about if they're still menstruating is to not have your flight physical while you're menstruating. And the reason being is that although we are only testing for protein and glucose as AMEs, if you are menstruating, and there is what we call gross blood or visible blood in the urine, that will raise questions because gross blood can come from the kidneys, from the bladder. But if you're menstruating, more than likely it's coming from a different area, right? It's coming from the uterus. So it's best, if possible, to not be menstruating when you do your flight physical, just to avoid kind of a cross contamination, we'll say, of blood in the urine sample. It's easy to explain, but it's difficult for the AME going, well, is this blood in the urine because of a kidney stone, which is something that's a problem, or is this just menstruation? So if it can be avoided, I know sometimes scheduling, it just can't, but make sure that if you cannot avoid it, make sure you let them know that could be part of the issue. It also can kind of make sure you're hydrated because we do look for protein, and sometimes heavily concentrated urines can test positive for protein. And trace protein's fine, but so I'd say stay well hydrated. Try not to go when you're menstruating. That's just kind of one of my biggest tricks for the urinalysis. Other things kind of segueing into if you are needing an EKG for your, let's say, class one, or let's say you just want to get one because you're deciding if you're going to get a class one flight physical. I do have capes. Capes are those, those little paper things that you can wear. And I've only had to use it once in the last 2 years because someone came in a dress. And so we had to figure out a cape situation because she was wearing a dress. But if I have someone that comes in and they're wearing a sports bra and a tank top, or a sports bra in general, or even a loose fitting, but front button shirt with a sports bra, there's really no reason for me to take the sports bra off. So you don't have to be physically exposed. Take everything off, your bra, your shirt, the whole thing. Now, not every AME is the same, but I just personally felt like I don't like laying on an exam table with the girls out and feeling like, then you got to put these cold stickers on me, and then I'm sitting here like awkward. Even if they have a female nurse, you're just kind of like, this is awkward. So actually, I find it really helpful in a wireless sports bra, because where we place the leads, the sports bra, actually the rubber portion of the sports bra actually holds the leads in place for me so they don't move. So I love when someone comes in a sports bra, because I can move the leads around and it actually kind of keeps it adhered to the skin. Awesome. And then the other leads go on the arms and legs. So I would say, if you're not sure if your provider has a cape, or because that could happen, and then you're just exposed, maybe consider coming in a button down shirt. That way, that is kind of your makeshift cape. And consider a sports bra. Keep it wireless, just because I don't know. I mean, some machines could be sensitive. Again, these are electrical impulses, so you don't want there to be something that could interfere with the electrical impulses. So, a button down shirt or tank top with a wireless sports bra is kind of my biggest thing if you're going to have an EKG. Now, again, you might have an AME that doesn't care and says take it all off. But if it's me, I'm excited about that. And you can always ask, do you mind if I leave my sports bra on? Can we do this test? I'll lift it up. This is, if they worst they could say is no. But honestly, to me, I find it helpful. Also, a chaperone, just to add to that, if you are allowed to have somebody in the room, especially if it's a new AME and you maybe don't feel quite as comfortable, you are absolutely, it is within your right to say, hey, can my friend come in? Or I prefer there be a chaperone with me during this part of the exam. Totally fine. And honestly, the medical provider might even be relieved that there's a chaperone. So don't be afraid to actually have somebody in the exam with you if you're going to be doing something that is of a sensitive nature, like an EKG that would expose your breasts. One other note, on the lower body, we'll call it the pelvic. There should not be a pelvic exam during an AME flight physical. There's no need for them to do an actual internal pelvic exam. There's no need for them to look at the genitalia unless you ask. And that is in the AME guide, for reference, at FAA.gov. But there shouldn't be any reason that someone is doing a genital exam, again, unless there is an absolute reason. If let's say you have had a recent surgery, I'll give something as private as a hemorrhoidectomy, okay? Not something you want to have to show your AME. And chances are it's not going to cause sudden incapacitation in flight. But let's say you just had it and you're coming back from something that's a private surgery. You can always just bring a note from your primary with a recent exam stating what they saw. And I feel like that should probably be sufficient. Sorry to go on and on.
No, I'm really glad that you said that, because I would like women out there that if they are feeling uncomfortable or they are wondering if an exam that has occurred or may occur in the future is normal, I'm glad that you're clearing that up, at least now that they can be like, wait, and they can ask questions, if it
Sure.
has come up, or if has happened, maybe that wasn't necessarily it wasn't necessary.
Right. Yeah. And every case is different, of course. You know, let's say you've got a breast lump, and sometimes an AME is a female pilot's primary care physician, and so they're just kind of doing both exams at the same time. And so again, it's consent. So like any examination, what you're consenting for. And I think that's sort of when, if your primary care doctor is also your AME, then those exams may occur because they're your primary care doctor. So they feel comfortable doing those exams. But the newest AME guidance is that that isn't something that is required, and so unless it is asked for or felt appropriate, it does not need to be done. There's no rectal exams that should be happening, I guess, in an AME. Um, Not normally. We'll say that. Yeah. Thank heavens. That would be a lot, right? So you're already
Any
nervous enough.
I know it is. You are nervous. And that's a good point. Let's speak to that because my dad was with United for many years and he always wanted to stay in good graces with his AME.
Yeah.
And I was like, what difference does it make? And
Hmm.
I do know that there are AMEs that tend to really be by the book.
Hmm.
And I think that the fear is that your AME is going to look for reasons to ground you rather than reasons to help keep you flying. And so let's speak to the have you come across that too? Because obviously you seem very much like an advocate. And if something is wrong, and I have personally been through the process of getting my medical back after postpartum complications. So I know what it takes to go through all that. But why do some AMEs seem to want to ground people rather than there's other AMEs that want to help guide you to keep you flying. Do you know what I mean? And that's
Yeah.
why
Yeah.
people get nervous, yeah.
I think I think that's more of a personality, and a style, to be honest. The FAA's training, they don't stand up there and tell us, you better catch something, like you be lurking for the gotcha moment. Honestly, the FAA is very pro prevention, right? So their job is not to treat, and just like my job is not to treat. I am not supposed to be a treating provider. The relationship is not that of a patient physician treatment. I am here to examine and look for industry standards, aeromedical standards. And I'm a little unique, though, in that I have done internal medicine for so many years that if I see something that could be a problem later on, I'm going to say something. And I say that because I've shared with you some of the reasons why I became an AME, and I am a full time AME. I 1 day a week I do obesity and wellness, and I see pilots for that. So I'm very much my practice is very much aeromedical now. I don't still do shifts in the hospital. I went straight into becoming an AME. And you and I had talked about how I had a friend who was kind of neglecting signs and symptoms of colon cancer. Eventually, we figured out he had colon cancer, but he had been neglecting those signs and symptoms for too long. And I shared with you that because of his fear of discussing them with his AME and because of his fears of losing his position, signing on with JetBlue and being in this sort of holding pattern, he didn't say anything. And he ended up, it did not end well for him. So he ended up getting diagnosed with stage 4 colon cancer, again, took more shortcuts to try to, again, get back to flying, and he passed away. So that was one of my inspirations for becoming an AME, was because I had heard and seen all of those stories at first, and decided that that isn't the type of situation I want anyone to feel like they're in. And I had actually shared with you some of my own experience as a physician, having to disclose mental health history, having to disclose mental health information. When I am getting credentialed at a hospital, they ask you a lot of the same questions, not as much as a pilot, though. And so it's a very different situation. But I came from a place of going, this doesn't have to be like this. Your AME doesn't have to be somebody that you're scared of. Your AME can be somebody that, hey, if I'm thinking about having this surgery, or hey, my blood pressure is a little bit high, I don't want to be on medications because the FAA won't let me. No, they will let you. So in these conferences, suffice to say, in these conferences that I go to with the FAA, there are so many ways to help with the treatment of a problem, and to get your special issuance if needed, or to get your khaki if needed, or to understand the documentation if needed. They are not looking to ground. They are looking to keep the skies safe. right? We're all looking to do that, you know? Pilots are very responsible people, very intelligent, um, responsible people, and they're very responsible with their health because their job depends on it. But nowhere in any of that training was it that we're trying to do play tricks on you or make sure you catch them, ask them this so that they'll say this. And no, if anything, it was try to have a good rapport with your pilots. Try to be somebody that they can actually be honest with and have pathways for them. And so that's why I actually offer consultation services. Like, don't just show up to the appointment and go, oh, I had a kidney stone. I was in the ER last week. Call me first. Let's talk about this. Here's the records we're going to need. Here's what the FAA is going to want. Let's not just submit an application that has nothing to look at. They need information. Every time I've called any of the Oklahoma doctors, they have all been reasonable. I mean, I'm not getting on the phone and they're telling me something yet. I mean, no, these are these are retired flight surgeons. These are, um, retired AMEs. These are people who have been in the aeromedical field. A lot of these docs, with the VA disability benefits, they're like, I'm on VA disability too. Like, I get that these documents make this pilot look debilitated. I was there. I've done this. Let them know we understand what this looks like, and we're here to try to work through. But we need the paperwork. We need the documentation. 90% of the time when a case is deferred or denied, or considered disqualifying, it's because they don't have enough information on their end to make a decision. They're not the ones sitting in the room with you. I am, or the AME is. So if we don't work as a team and get them the documentation they need to make the higher level decisions, the answer is always going to be no, because we're missing this. But I always tell my pilots when they get a letter from the FAA, the first two paragraphs are really hard to read. And it's probably because it was written by their legal team. It's very much because of this diagnosis, you don't meet the criteria based on this code. So then everyone stops reading because they're like, great, I got denied, or great, it's just great, another letter. I just had one of those calls today. And I said, did you look at the page two? Well, no, my friend got it. It was certified. They only sent me the first page and I'm freaking out. I'm like, read the other 4 pages, because that is a blanket statement of, yes, that is true. But there's generally something below that that says, however, if we receive these 4 bullets, these 7 bullets, these 17 bullets, whatever the diagnosis is, we will we will reconsider. And they do. And I'm dealing with these letters all the time. And the reconsiderations are legitimate, valuable questions. Hey, we want a progress note about that thyroid problem, or hey, we want to know a little more about your PTSD rating. So again, one of the reasons I am full-time AME is you kind of have to have time to work these cases and patience. And there is a doctor of the day available on call in Oklahoma every day of the week, on Oklahoma time. I think it's 9 to 4 or 8 to 4. And so I can put in a request to get a call back from a doctor in Oklahoma and review a case. And they call me back every time. So I think it's important and valuable to do this full time, which is why I do it. And it's not a side gig for me. It's not a retirement gig for me. It's a full time dedication. And so not every AME is doing it in that way or has that capacity. That doesn't mean they're doing it wrong. It just means that if you do have a complicated case, that maybe a consultation prior to your appointment would be the better way to go about it, so that you don't feel like they're trying to be sneaky, or they just hit the deferral button and just, this has got to be deferred, rather than having a more meaningful conversation, which may take more time. I hope that answers the question. I know I just went in a big roundabout explanation, but I have never been to an AME conference where I felt like, man, they really want us to just find something on these people to ground them. No, that has not been the case. I know there's the whole, you're not happy if the FAA, there's a saying, and I'm ruining it, something about if the FAA, you're not happy unless the FAA is not happy. You know what I'm talking about?
I don't know the exact saying, but
But
the
it's a funny,
takeaway
yeah,
is
yeah,
that you, the AME, can actually be the person that somebody consults with, because
yes,
there are, companies out there that's what they do. Call
absolutely,
us
yep,
before you call the AME, and
hmm,
sometimes it's covered by your union.
AMAS, yeah,
AMAS, yep, we'll go
Hmm.
ahead and say AMAS, or if you're not an Alpha member, then maybe
Hmm.
it's not covered, but
Right.
so maybe people are paying out of pocket for a
Sure.
consultation when in reality, maybe they just haven't found the right AME. If they're fearful of asking their AME, oh, my AirPod, if they're fearful of asking their AME these questions as a consult before they come in, maybe that's not the right AME because what I'm hearing you say is I am available. We need to talk about it. We need to know the information. It's not an automatic no. It's can you provide the information? But
Right.
you're not going to automatically ground somebody. It's not to be you're not to be feared. And because I think that that's AMEs are to be somewhat feared in the
Yes.
industry because
Yes.
you this is our livelihood and
Right.
too much information could take away our livelihood.
Right.
So that was
Right.
my takeaway from everything you said.
Yeah. I joke that I have worked in a hospital setting for 20 years, and the majority, well, all of my patients, majority, came through the emergency room. So if a patient came into the hospital, if they were sick enough to not be able to be discharged from the ER, they saw me. So I saw all the sick people in the hospital, from strokes to amputations to whatever it was, I saw them in the hospital. And so I'm used to people on the worst day of their life and the fear and people dying, the whole thing. And the fear, I'm pointing to my door because the fear for my new patients, the fear on their face when they come into my office is worse sometimes than the fear of the emergency room patients I would see. And I joke with them, I'm like, what are we scared of? They're like, you, because you could ruin everything. So I try to, my office is in an airport. It's a small area. It's Coeur d'Alene Airport. I've got funny things all over. I've got a joke of the day. I've got funny, really naughty curse word candles. Like I try to make this room very calm. I have pictures from my patients. I do my best. I don't wear a white coat. I try to make it as calm as possible. It's still nerve wracking the first time they see me, and think after that, once a little bit of rapport is established, they know they have my cell phone number. I do consultations from all over. I had a consult just a week ago from Istanbul, Turkey. I had another one from Dubai. I had one from New York. And so I do consultation independent of being your AME. So if you have an AME that you feel like you can't get in to see and you want to talk to an AME about your case, say you have a question, you're not sure where to find the information, you want to be prepared, but you can't, your AME just does AME appointments. You can actually consult with me via Zoom. I have appointments available to do that and to just kind of prep you and go, okay, here's what you're going to need. Here's what, if it's a huge case, there are companies like you mentioned that can help with records and things like that you can pay. It really depends on how complicated the case is. And I have sent a couple of those patients that have called me to those companies and said, you need a team of people to get this going. So there are opportunities for that. The information is actually online. When you fill out your MedExpress, there's a link and it says, check the AME guide for your diagnosis and print it out. I feel like that's the same as somebody telling you, well, my engine's making this noise. Well, check the handbook, check your manual and fix it yourself. You could, right? You could find all this information yourself online, but could you understand what, VTE, PE, means when you look at I'm just looking at the hormone replacement thing on here. It's because we were just talking about it. You'd go, what does that mean? So it's helpful to have someone interpret the information, but the information is actually available on the FAA's website. There's a almost 900-page AME guide that literally tells you everything that I'm going to tell you. It's just the interpretation is this isn't the language that you guys speak, right? So that's why I offer the service to try to lower the pulse and the blood pressure.
I speak from experience that one other benefit to maybe some of these companies, if you do have a complex or a big case, is advocacy with the doctors that are not familiar with the FAA. And I speak from experience
Yes.
because I was told one of my bullet points on my letter was to get an extra MRI on my brain.
Hmm.
And because I dealt with postpartum preeclampsia and then another issue that was related to that. So my neurologist said, "No, I treated you. I released you from my care. You are no longer afflicted with this, and I released you like as of December of last year. So why would I order an MRI for you? That's unnecessary." And I
Hmm.
said, "Well, because the FAA wants it." "Well, I'm your doctor, and I'm saying no." And I'm like, "Okay." So, and here we go again. This is my livelihood.
This is my job,
So,
sir or
yep,
ma'am.
this is yeah, this, sir, this is my job. And he kind of got into a pissing contest with the neurologists over
Uh,
there in Oklahoma City. And that's when I think a company like that could help you. My neurologist ended up relenting, and he agreed to just order the MRI after I called him, and I'm like, "Come on, bud." Um, so I can that's another, if anybody finds themselves in this position in the future, I feel like maybe if your AME is busy or has a lot going on, an AMAS type of service might be able to help in that kind of a circumstance,
yeah,
because it happens. Happened
yeah,
to me. That probably put me back maybe a month with
yeah.
getting, yeah, all said and done.
And I have kind of two stories as far as advocacy goes. And I do know a lot of the providers out here. So when they are giving a lot of huff and puff answers about, well, why is this necessary? And I find this so unnecessary, and blah, 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 I'll just call them. The patients will tell me, or the pilots will tell me, yeah, they don't want to order it. They said this and that. And they'll even write it in their notes. Sometimes they'll like fight with the FAA in their note. So sometimes I will just reach out to them and say, hey, like, I know I know, and you are not aeromedically trained, and I get it. This is the standard. This is a safety standard. It's different than an activities of daily living standard, and you don't have to agree with it. I don't always agree with it, but it's not my job to agree or disagree. It's to uphold that standard. Most of the time, it when I'm defending the test, it isn't one that I think is absolutely absurd. But I just explain to them, here's why, and they're not gonna budge on this. So we got to do this. Certain things. And they'll say, that's not standard of care. And I'll tell them, I've been an internal medicine doctor for 20 plus years. I know it's not. I don't need that education, but it's an aeromedical standard. They're different. And so having that conversation is fun for me actually. And because I'm in a smallish town, kind of know everybody. So it's easier. I also have some specialists that I know, specifically cardiology, that deal with aeromedical things. So sometimes it's just the education. And then other situations I have, like I had a gal have a patient who had melanoma on her skull, and they wanted her to do a ton of scans. Specifically, they wanted her to do total body CTs and brain MRI, a PET CT to look for metastases. It was a very, very big melanoma, but it had never invaded her brain. So her cancer specialist said, "Hey, we're exposing this young woman, to radiation every single year. And MRIs are different. It's magnets, but PET CTs are CAT scans and their radiation. And so they were very concerned with ordering this test because guess who's liable? The ordering provider, right? And they said there's this new genetic test that we can do. And I think it'd be more appropriate for her. So they wrote a letter, and she asked me if I could advocate for her to get it removed, the PET CT removed. And I did, and we did. So I told them, I said, this is I don't remember how old she is, but a young woman that the FAA is mandating get essentially exposed to radiation. I know that's not the intent, but that's the concern of her cancer specialist, who doesn't want her to end up with something else from all of this radiation exposure done annually for aeromedical reasons. They're not fine. Here's an alternative. And they said, like within an hour, I got a response. Absolutely. I think this is the way we've always done it. This is the protocol, but there are different situations. And sometimes it's just sort of hey, is this still necessary? Or, hey, there's this new test that now replaces this. Can we do this instead? And they've actually been pretty amenable to that suggestion. And I had another case like that. So I have done some of that for my patients. And it's gone really well. And if they decide that they don't want to use the alternative test, then they usually give a really, really valid reason why they don't want to do the alternative test. But again, that's why it's great to have those doctors that are on call each day to be able to have a conversation and say, what do you think about this? Does this sound reasonable to you? And they're reasonable providers. So there's kind of two sides to that. You can make a request to have certain things removed if your provider feels very strongly, but understand that they still have the final say when it comes to the aeromedical factors.
This is We were talking before we started recording about how there isn't nearly as much guidance for female specific
Hmm.
issues, medical issues in the FAA medical book, and that it's becoming a little bit more common now.
Hmm.
So, one of the things that we talked about right before we started recording was HRT, hormone replacement therapy,
Yep.
and how that is becoming common for women starting in their 40s,
Hmm.
maybe earlier. And so one thing that you just discovered is that there was something new as of April for
Ah,
hormone replacement therapy. So, because I know at least in my groups online, this has come up. So, if we can speak to that and how it just very recently, this has become something that is addressing women's health and
right.
hormones for women, because that's a positive for sure.
Right. Yeah, so there's the most recent updated clinical guidelines in the AME guide for hormone replacement therapy, and I'm kind of looking right because I have it open on my screen. There's a disposition table that you can actually even Google. If you want to know anything in the AME guide, I always tell people put the diagnosis, so or whatever you're looking for, hormone replacement, and then the letters FAA and then AME. And as long as you put those FAA and AME, it will bring up probably a bunch of things, but look for the .gov at the end, and that'll be the source, and it'll bring up the page in the AME guide. So that's honestly the easiest way to get the most updated information. So yes, as of April 29th of 2020, this was updated, and for hormone replacement using estrogen, progesterone, or testosterone in women, as long as you're near physiologic levels, and that's an important caveat, meaning you're not over under. More so, they're probably talking about testosterone in that comment. If an AME can determine that there's no side effects that are interfering with flight duties, and there's no history, and this is kind of the big one, that there's no history in this person of a VTE, and that stands essentially for a blood clot. So has this person ever had a hormone related blood clot, whether it's in their leg, in their lung, or anywhere in their body? Because sometimes hormone replacement therapy can cause a hypercoagulable state. That is important in the aeromedical factors, we'll say, because a blood clot can lead to sudden death if it's in your lung. It can lead to cardiac arrest. So these things can be obviously life threatening. People understand blood clots to be life threatening. And so that's where they're worried. So as long as we can determine that they haven't had that history and there's no history of increased risk of stroke, uncontrolled high blood pressure, or severe migraine, because sometimes you can get migraines with the fluctuations of hormones, there is no deferral. It is we comment that these things are all okay. We summarize in box 60, which is our box where we can write all the different things. It's the last box on the page. The only time you really have to defer, meaning that you cannot issue and you need to kind of escalate to the FAA, is if there is a history of venous thromboembolism, blood clot, stroke, then you would need to defer for an FAA decision. Um, and there's a whole list of things that you wouldn't just want to go in and say, I'm starting hormone, or I started hormone replacement therapy and I have a history of blood clot for being on birth control pills when I was younger, because the AME is going to go, wait a minute. When you defer something, you should never defer a blank exam. There is nothing more annoying, probably, and I will go on the record to say there's probably nothing more annoying than the FAA getting a deferral with just the exam and like no documents or backup explanation, because they're going to go, what do you want me to do with this? Then you're going to waste time, because then they're going to have to type up their letter to say this is what we need. Or it's literally in the AME guide. Your AME can guide you through it. It's current detailed clinical progress note from your treating clinician, summary of what happened during your blood clot, a physical exam, kind of talk about what the situation was. Was it even related to hormone replacement, or did you have a surgery and then you ended up with a blood clot? So any labs or imaging they want to see, uh, because they're not the ones in front of you, right? They're not sitting in front of you having this conversation. They're just getting your MedExpress form with nothing attached. And so I will tell you that would be annoying to any medical doctor trying to make a decision about a case without any supporting documentation. So for the most part, in most cases, HRT, per our guidelines, is going to be okay. It's if there's a history of blood clots where it could become tricky. And honestly, your treating clinician for the hormones will want to know about your blood clot history too, because they're not going to want to be surprised by your first DVT in your leg when you started HRT. So they're going to be cognizant of that as well. And so writing a note about that, whether you're an aeromedical doctor or not, is going to be what we call a standard of care. So this isn't weird. This would still be standard of care for anyone starting HRT.
So, with regards to reporting
Yeah.
things, and I guess this would be different if you're getting your very first medical, because then you do need to, I mean, we'll just take HRT, but then we'll segue into coming back from postpartum, with your prenatal care and postpartum care. How do you know what to report? I mean, depending on when you go to get your first medical or when you are coming back after an absence and looking to get your first medical after being gone, what do you like significant events, obviously, significant health events, such as a blood clot, that would be very helpful. I'm thinking
Yeah.
about you saying that you don't want to show up with a blank anything. So, but then, people have been to the doctor many, many times before in their life. What is significant for somebody that's just coming in for a medical, or that segues into what do you report when you have had like an event such as a birth?
Mhm.
That's unique to women. Men don't have to think about how to report this. How do you report all of the appointments
Yeah.
or just a few?
Yeah. So um, when I type in the word pregnancy in the AME guide, and I just did it, there's like 5 places that it shows up, but it has nothing to do with what you're asking. And so I don't know that there is a hard and fast, but let's say somebody has a high risk pregnancy and they're seeing their OB on a regular basis and they're getting a ton of prenatal visits. You're probably going to run out of room on your Med Express. So this is not the end all be all advice, but what I would tell my patient would be maybe break it up into trimesters. Say, okay, in the first trimester, put one appointment, the most recent appointment, and then in the description, of what occurred, was doing this twice a week or twice a month from the months of this and this. There's an explanation box for a lot of things for you. There's a general explanation where you can literally go in and say, these were my appointments. I just put the most recent, or I broke them up into the trimesters, or whatever the scenario was. But I think I gave you another example of somebody going through physical therapy. Again, they're looking for medical provider. So some people go, well, does that mean physical therapy too? Or if I'm just getting the ultrasound, I would try to group them. I think if I were the one reading the Med Express, I would go, oh my God, there's 50 visits on here. Could we have consolidated this? Probably. So whether you consolidate them by trimester or you just consolidate the last 9 months, however much time is in between your flight physicals, this is the provider. This is how many times I had to see them, unless again something was discovered in one of those visits that wasn't routine, like I have gestational diabetes now, or I have my blood pressure started to go up, or whatever the situation. Then you probably would want to report that in a separate entry so you could explain it. But if it's standard routine, getting my ultrasound, everything looks great, probably okay to cluster those together. If I were the person reading them, I would probably want them grouped together. I don't have an official statement on that to say that. But if someone came in and grouped them, I would go, "Yeah, thank you." Because I've had people come in and they come in with like a Word document because they couldn't fit them all. And then they want me to enter them. I'm like, well, there's not enough room. So I think consolidating them is probably okay as long as they all were within normal. And if they weren't, then outline the ones that were not. Does that answer your question?
It does,
Okay.
because that also helps answer my question if, for example, you, the woman, the pregnant person, is perfectly healthy, but maybe there's something going on with baby and you have to go to
Mm,
like an MFM or something. So maybe grouping MFM appointments to
yes.
say, yeah, kiddo was dealing with this and this and this, but because that keeps it separate from you, but you're still being seen by a medical provider.
Right.
So,
Right.
yeah.
And then there's a whole, and that's probably, and I would have to, we didn't get into this, but we can on a later podcast. There's a whole fertility drug question. And there isn't anything outlined in the AME guide actually for fertility drugs. I did reach out to a regional flight surgeon though. And so I did get a breakdown of kind of the common fertility drugs that women use and what the wait times are for those. And so we can do something separate if you want on, because that's a whole animal in and of itself. Is I'm about to start fertility treatments. um, what do I do? What are the self grounding? What should I agree to? What should I not agree to? Because of course the maternal fetal does not, they're not going to know. They're just going to go, here's standard of care. um, in that same, oh, I just had a thought and then it just boop, it's gone. Maybe it'll come back. Had to do with fertility. Oh, um, real quick back on HRT. I had a female pilot call me. She's one of my patients, and she said, my doctor wants to put me on, I'm pretty sure it was a Fexer, for menopause symptoms, for perimenopause symptoms. And my eyes got enormous because I was like, no. So if Effexor, I'm just going to make sure it's the right drug that I'm, is a it is for, it's an antidepressant, and it is used off label for hot flashes because of the way that it works. However, if you are not a pilot, that's probably maybe okay to use for off label if you want to avoid hormones. But if you are a pilot, you've now just started an antidepressant. And it doesn't matter why. It is an antidepressant. So it is a totally different antidepressant pathway. I did have a consult with her and said, are you having depression symptoms? Are they considering this for depression? She goes, no, I was just having hot flashes. And I had to look it up because I had never heard of that. And it's because it's off label. And I said, it's an off label indication. I'm sure it's wonderful for hot flashes. I think you need to make a decision with your, maybe let your primary know this isn't something that is going to be easy for you to be on for your medical. And she goes, oh no, I'll just do hormones then. I'm like, okay. So sometimes there are off-label medications that are not approved, right? So it's one of those things that, well, it was just for menopause or perimenopause. It doesn't. The indication and the medication, they kind of have to align. And so again, that's where standard practice, off-label practice, and aeromedical practice don't always align. So I'm glad she asked me first. We had a conversation, made sure that she didn't really need an antidepressant. Again, I'm not her treating provider. I just gave her guidance that this is what this would look like, and this is what this would look like for your medical. But do what's best for you. Don't fly with hot flash. But she's doing fine. She did not start Effexor, but it was just alarming. Like, oh yeah, I forgot. Just like Cymbalta can be used for pain management. Cymbalta is an antidepressant medication. So although it can be used to avoid opiates for pain, it's an antidepressant medication. So it's great for people not flying it, for the average person. But there are considerations to be made when you're a pilot. So
And we should mention that you and I did talk about how there's a lot of questions on antidepressants and what the latest is on how to go through the entire it's the HIMSS program. And a lot of people don't know that it's the HIMSS program, and then maybe after at the end you can briefly explain because you mentioned that you're a HIMSS AME, and I
yeah,
think that maybe newer pilots because once we get to an airline, the hymns people come in and do the whole spiel. So
yeah,
I think most major and probably regional airline pilots are familiar with hymns, but maybe student pilots aren't that familiar. So we can briefly explain what the hymns program is. But you and I agreed that an entirely separate
yes.
podcast is
It's
going to
a
be dedicated to mental health,
Yeah.
mental health medications,
Yep.
what needs to be reported, how long you need to take or give yourself. Obviously, do what's best for you, like we
Right.
talked about earlier in this episode. You need to take care of yourself, number one, but what that will look like. And so you and I are going to talk again soon about that. So if everybody's wondering, like, are you going to talk about that? Yes, but you said it was a completely different animal.
Yeah, I don't want to, it's, you don't want to, you want to give it justice. And the HIMSS program isn't just for the mental health bucket. So the HIMSS program is this broad sweeping umbrella term for actually the drug and alcohol program for pilots. And so there's like HIMSS light, sometimes it's referred to, that is the SSRI or antidepressant pathway or ADHD pathway. And so they're clustered together at this time. I don't know if that's going to change. It could. And then there's a whole, well, then we can talk about counseling and what kind of counseling you report. And so it is its own animal. And even the drug and alcohol should not be discussed at the same time as the mental health, because those are separate, those are separate pathways in a sense. They're just under the same guidance. So, and I am a HIMSS AME and I do all of the above. But yes, we should do that. I'm not avoiding it. We're going to do it. We just don't want to do it in 5 minutes and then everyone go, why don't you talk more about that? So, and actually, I'm going to be on a mental health panel at Oshkosh if anyone's going to Oshkosh this year. There are 2 mental health panels that are going to be put on by AOPA and Dr. Susan Northrup, the legal counsel for AOPA, myself, other people from AOPA will be there to answer a Q&A. 2 days, I think it's Monday and Thursday. So if anyone's going and is interested in seeing that, that is happening and it should be out once Oshkosh has its sort of schedule out. So it is it's a hot topic. They are very interested in figuring things out. There have been advancements, but its own baby, its own animal, in another podcast.
Okay. Yes, this one was going to be dedicated to women-specific issues. The
Yes.
next one we briefly spoke about was PCOS, which
Yep.
I do realize was like within the last month renamed to something else. It's no longer PCOS, but that's what we'll call it. They just recently changed it. I don't remember what it was, but they just changed the name of PCOS to something else.
Hmm.
There's an
Well,
M, I think.
it is still PCOS for the purposes of the aeromedical for the AME
Okay.
guide.
Okay.
And so I do have that pulled up as well. That was I only have the most recent updates 2023. Not that there's been a whole lot of updates to the diagnosis itself, but so essentially PCOS, for those that don't know what it stands for, is polycystic ovarian syndrome, and a, it's it's a syndrome where you can have cysts on your ovaries. However, you don't always have cysts on your ovaries to have the diagnosis. Sometimes you have other hormonal changes, male patterned hair, irregular menses, or irregular periods. So there's other ways to diagnose it. But if you have it, you know you have it. Um, so essentially, you can state that you have, there's a box for other illness, disability, or surgery, and you click and say PCOS. And if the condition's under control, you're not on any medications, symptoms do not interfere with flight, then the AME simply says this person has PCOS that's controlled off medications. If Then there's another box. So you can be on medications with PCOS. There is a list of medications, and PCOS is actually something called a CACI, or a condition an AME can issue, meaning it does not require generally a deferral. If you meet certain criteria, the AME can go through those criteria with you and you can actually get your medical issued. The criteria are online. Again, I'm reading them verbatim online. And so if you would need to see your treating clinician, whether that's your primary care doctor or your OBGYN, within 90 days of your AME exam. So a current to the FAA usually means within 90 days of seeing your AME. That's not for everything, but that's generally what these CACIs are. And you bring that note to your primary or to your AME, and they look through this and go, okay, first thing on here is, does the note state that this regimen is stable, that there's no side effects from the medication, cardiovascular risk is controlled, is there any concern about sleep apnea? And the reason they bring that up is because PCOS patients tend to hold more weight, be heavier, way more, and have problems with obesity. And so with weight gain comes sleep apnea. So that's why one of those questions is on there. And you can have sleep apnea and be on a special issuance, and it's like actually one of the easiest ones. That's a whole other podcast as well. Any evidence of depression or anxiety, as indicated by a current a risk score. So your primary would, honestly, I would just bring this khaki form to your primary and say, I need you to address these things for my AME, be the easiest thing to do. Any evidence of diabetes or prolactinoma. Prolactinoma is a type of tumor in the prolactin gland, which is can be affected, and diabetes, because you can have diabetes with PCOS as well. So they want to know if there are associated syndromes with the PCOS. And then acceptable medication list. Usually we're going to see spironolactone, metformin, oral contraceptives, letrozole, finasteride. Those are mostly for when you're seeing the male hair patterns, but they all can be used. We were discussing that GLP-1s, like your Manjaro and your Wegovys, excuse me, your Zepbounds and your Wegovys, those are starting. There are some clinical trials right now for treating PCOS or using them in PCOS patients. I personally do use them in PCOS patients that have weight management issues. Starts to regulate their period. They get pregnant, which is very difficult for PCOS patients to do. And so I have a feeling the GLP-1s are going to be added, who knows how long, to the list of acceptable medications that treat PCOS. But for now, those medications are treating weight. That's also a khaki. You can be on them as a pilot. So if you have a dual diagnosis of obesity with PCOS, that medication would just fall under the obesity instead of the PCOS. But we are seeing really good trials with that medication. So then if you meet all those criteria, the AME writes khaki qualified polycystic ovarian syndrome or PCOS, and you go about your life. But you do need to have a good note that kind of addresses all of those things. I hate to say this, but especially if you have a male AME who, maybe isn't even an internist, it's like, what is it? Not to say that only men wouldn't know this. Like if you have a female AME who may not know, don't leave anything up for question, right? They're not your treating provider. Your AME is not meant to be your treating provider. Bring the note in from your treating provider that addresses all the khaki criteria. And again, if you need to look for it, put khaki, which is CACI, condition AME can issue, khaki, PCOS, FAA, AME. And you will get the exact same thing that I just got, which is the khaki form explaining all the things that your primary needs to address. Hand it to them and go, please, please and thank you. And it has to be during an exam though. So understand that when they are asking for a progress note, they're not asking you to go get a note from your primary addressing just, hey, can you write me a note? They're really looking for an examination, vital signs, medications. This is how they look today. This is my assessment of their physical being today. It can be telemedicine, but it has to be an actual progress note of how you're doing, not just a one paragraph, they're doing great. They specifically say that they want a clinical progress note generated from a clinic visit. So that's they're specific on that for a reason.
That's helpful because not everybody understands and knows that a note is a note.
Exactly. Or even sometimes I'll get the after visit summary. So a lot of clinics are in MyChart or Epic. And so you'll go into your MyChart and the first thing you'll see on your visit is after visit summary. So it's the first thing you click because it's in chronological order. You just click that one. All that is your handout after here's what your doctor saw you for. It's very patient focused. The box below that or the hyperlink below it says clinical notes, I'm pretty sure. Doesn't say progress note, it says clinical notes. I'm almost positive that's the wording. You click on that and then all of a sudden it's like your doctor's note verbatim. That's the note they want. They don't want the after visit summary. There aren't any physician notes in there that are helpful. Again, they're it's like when you go to the emergency room and they give you, here's what to do about your upper respiratory infection. Here's something we printed out from Medscape. But the clinical notes are the actual documentation from the physician, and that's what they mean by progress note.
bringing back memories. I did this
Sorry.
a few I did this a few years ago. I'm familiar. Yes,
Yeah.
the notes. Lastly, but it's helpful because we can't touch on every single medical issue that, you know, people didn't happen to see, "Hey, if you could ask an AME anything." Some people didn't see that, but it's helpful to know that you've really broken it down how to search for these things, so
Yes.
they can just get on and search for themselves. But, the last one was somebody was asking about Accutane, because
Hmm.
Accutane is a common, um, acne medication, and
Hmm.
so somebody was wondering because that would seem to be the only, medication that was effective for her. And
Right.
so what are the issues with Accutane?
Yeah, so I actually reached out on an Accutane case to the regional flight surgeons last year. I was sharing with you, and so from the guide, it essentially says for applicants using Accutane, there's a mandatory 2 week waiting period after you start it. So 2 week wait prior to consideration. And the reason is it's because it's associated with vision and psychiatric side effects, and specifically night vision. So if you're currently taking it, the side effects can occur even after you stop it. So that's why they're picky, as you can imagine. They're always picky about the eyeballs and the brain. So if there's any kind of psychiatric nuances or vision problems, they're gonna be all about it. So if there's any history of psychiatric side effects, then it requires an FAA decision. And anytime you see that requires FAA decision, that just means that it doesn't mean you're denied. It means you're deferred. Your AME cannot make the decision. It requires a higher level decision by the FAA. If there are no vision, psychiatric, or other aeromedically unacceptable side effects, you can issue the medical, but you have to issue it with a not valid for night flying restriction. And then if you want that restriction removed as the pilot, then you would have to do, like, I'm assuming there's some kind of appeals process. So I was reading this before we started talking, and you can make a consideration or put something in. Probably would require a letter from your treating clinician, whether it's dermatologist or your primary, that you don't have all of these things and everything's going well, how long you've been on the medication, how you're tolerating it, um, and then an eye exam. And they are actually commenting on a specific eye exam. There's a form 8500-7. I'm going to double check myself. I'd say this every day, but there's 8500-8 and 8500-7. 8500-7,
They ha
8500-8 is your Med
they have
Express.
you do the full vision mapping,
Yeah.
which
Yep.
is the glaucoma
Yep.
test. It's
Yep.
a spec Yep, because I had to do it. And they're not, even though it's a machine that's at your ophthalmologist,
Mhm.
you can't just ask them for it. You need a prescription
Oh,
to
interesting.
get the test done. Yep, for anybody that is wondering, I've had to do it. And they'll give you a really hard time, especially because I was, gosh, 41 when I was doing all this. They go,
Yeah.
"You don't have glaucoma." And they said, "Nope, that's not what it's for." And
Yeah.
they really don't want to let you just go in there and use that test. It's really, you really
You're
need
like,
to
I will pay
convince them.
cash.
Yeah.
Well, this is just asking for um, 8500-7. So the dash 7 doesn't have there's a name for the one that you're talking about. It's like a person's name who invented it or something. The 8500-7 is a form that is just a report of an eye exam. And it goes through, I actually tell a lot of my pilots, if you're nervous about the eye exam or you already get glasses, um, get your prescription renewed the month before you see me. Have them fill this form out. If everything looks good, we can skip my eye exam, most of it. I mean, we can skip the near, intermediate, distant. If we have to do hypertropia, that would be separate unless it's documented that they did it. But that is totally fine. I've asked the FAA that question because my pilots are like, I'm already going to an optometrist every single year to get glasses. And I'm great. Bring me, have them fill out this form exactly as the FAA wants it, show it to me. If it meets your standards, we're done. We don't have to do my exam. And like I said, I'd asked the FAA about this because I had a patient who had been doing that, asked me to do it. And I'm like, makes sense to me. I mean, an optometrist equipment, I mean, I have a machine, but I'm not dilating you. I'm not an optometrist or an ophthalmologist. So their exam and they're checking pressures, and I mean it's so much more thorough that it would make sense we can use it, and we can. Not every You don't have to use it, but why wouldn't you use it if an optometrist did the exam? So a little caveat there about the eye exam: you can actually have the 8500-7 form filled out and bring it in, and your AME can choose to accept that. But the one you're talking about is a little more extensive for glaucoma, and sometimes they will ask for that, and they might for the Accutane. I don't have, other than what I just read you from when I had asked the regional flight surgeons in the past, I don't have anything more specific on Accutane, other than sort of the explanation for why they would consider it a deferral, or that there'd be a night vision restriction. But you can make a consideration to have that lifted, it looks like. So,
Yeah, and to be clear, the FAA doesn't think you have glaucoma. It's the machine that they use to
mhm,
diagnose glaucoma, but it is a full vision mapping to see if you have any blind spots in your periphery or
mhm.
anywhere in your vision. Yeah. So I had a condition that was, it's called RCVS. It's kind of rare. And
Yeah, we talked about
so,
that. I was like, what?
yeah, so if anybody has ever had RCVS, they treat it similarly to a stroke. And so I had to go through all of the tests to prove that I did not have a stroke, and if I had, my vision would be affected, and I had to take the stroke test and everything. So that's just a little sidebar for everybody. If you ever have RCVS,
In case it ever comes up again.
yeah, I think they said I was the first, the
Oh,
FAA. They had never heard of that prior to me.
I
So
I've I've had two firsts for them too, and I'm like, oh gosh, that's not good. But I guess we paved the way. We
I
paved the
am your
way for the
trailblazer.
next one. You're
I am your
welcome.
RCVS trailblazer, everyone. You're welcome. And I got it back. It took about 8 months. It took about 8 months for me to get my medical back after
You're
that.
lucky they didn't treat it as a full stroke, because a full stroke is 2 years,
Mhm,
depending on the location, 1 to 2 years. So
mhm.
it's tough. It's really tough.
Yeah,
I kind of go, "Phew," when I hear someone that says, "Oh, doc, I had it," I'm like, "Oh no, that's not a
yeah.
good one. That's not a good one." Well, I completely recovered. I'm like, I know. Remember how
Mhm.
we talked about standard of care and then aeromedical? It's different. I am obsessed now with finding the name of that darn test. I'm like, I've been going on while you were talking, trying to find the. It's the Humphrey Sita. No, that's not the one. I think it's the Sita, SITA,
The
is the test
The
that,
Humphrey sounds right.
or the
I
Humphrey.
re
Okay.
I remember Humphrey.
It's
Yeah.
like a bunch of little dots in your peripheral, but yeah. Yep.
Yes, it'll like
Somebody
little
named Humphrey.
stars, and
Yeah.
you have to click on something when you see the little star.
Oh.
Yeah,
Hmm.
that's how it, and then they'll be either bright or really dim, and
Mhm.
you still have to click when you see anything. And then you
Interesting.
start to wonder, did I actually see that or am I making that up?
Is it just like, is it just now now I have floaters. Now I don't know
Mhm.
what I'm seeing. Yeah. Yeah.
So, I think we've covered everything that we wanted to. This is already, we've been going at it for an hour. So, this has been so informative, but I do want to circle back to reiterate that if anybody is having any concerns or they are avoiding, particularly avoiding having any sort of exams or just general care or mammograms, colonoscopies, because, like your friend, my dad died at age 60 from colon cancer, and it was very aggressive. It was 2 years since his colonoscopy prior to that, and 15 months diagnosis to death as a international airline pilot. So I want to circle back to your original message and don't delay and don't avoid basic care and health
Right.
care because
Right.
that's number one. It's yes, this is your livelihood, but so many things. I know people that have come back from cancer and they are actively flying
Yep.
and they're back out. So yeah, I just want you to touch on that one more time before
Yeah.
we get going because
Abs-
it's so important, and I don't want people to have that fear of finding something, so they avoid.
yeah. Well, because Just because you don't look for it or don't see a primary or don't get your screening tests, don't mean you don't have that thing that you fear, right? So not getting your mammogram doesn't mean you won't get breast cancer. We all know that, but we talk ourselves out of it, and then years fly by and they're like, when was my last mammogram? Or they don't want to report it. They'll put haven't seen a doctor in the last 3 years. And anytime I see that on a Med Express, I go, really? Like, you haven't seen a primary? Or, oh, I don't have a primary. And then I have a stack of cards of primary care doctors in my desk. That's how important I think it is to get primary care for primary prevention. I have somebody I use locally, or I make recommendations, um, because honestly, that an FAA clinician looking at your Med Express, seeing that you haven't seen a doctor in 3 years, do you think they're like, oh, they're probably super healthy? No, they think that's a red flag. This person's 50 years old or 55 years old. They haven't seen a doctor in 3 years. Well, they're not getting their screening tests, and then we're missing all of these things. So you look more sus that you're not seeing a primary care than you think, right? Like, oh, I'm just going to check no for everything. It's like, well, except that you have to start getting your pap smears, mammogram. Like, there's an age for screening. It's not 18, right? But it's getting into your 40s, your 30s, depending on your family history. So looking responsible and being, it doesn't even matter looking, right? Like, it's not all about the way you look to the FAA. It's being responsible, getting your screening test. Because guess what? There are two that I can think of off the top of my head, cancers, which we touched on two of them, breast and colon, that you can continue to fly and get your medical if they are stage 1/stage 0. So you can literally find a breast cancer, stage 0 carcinoma in situ, and continue flying. Same thing with colon cancer. These are both CACs, condition AME can issue. So cancer is not always disqualifying. And I have a pilot who had a rare cancer. Again, it was one of their first that they had ever seen. He had had it resected, and his bucket list when he had this rare tumor, huge tumor resected from his abdomen, was that he wanted to learn how to fly an airplane. And he comes in and he's like, I had this rare tumor. And I thought, oh my God, they're going to laugh at me when I call them. He had his medical within 6 months. He just has to have routine follow up. But they said, we have not worked, I think it was paraganglioma case before. So we've got to kind of look into this. But sure enough, they figured it out, and he is flying an airplane. So I cannot reiterate enough that thinking that you, just because I don't see primary, I'm healthy, I don't need the screening test, I don't want to, just want to fly my airplane. That doesn't mean that your cells aren't mutating. It doesn't mean that your body isn't creating tumors, or that your blood pressure isn't causing you to get a brain aneurysm. Or, you know what I mean? So one of the biggest ones I see in here is high blood pressure. And one of the first questions I ask is this normal for you? Has someone else told you you have high blood pressure? Because of the downward effects of the blood pressure, right? Like, it's not the in the moment high blood pressure, it's the stroke that can happen from the spike. It's the heart attack that can happen. It's the hypertrophy of the cardiac muscle by not treating it for 10 years that can then lead to heart failure, which hypertension is treatable and is not a deferral. Heart failure is a different story, right? And so, or arrhythmias, AFib, things that can happen because you're ignoring, by not going to see your primary, by not getting treated for things that are easily treated, not controlling your weight. So again, burying your head in the sand doesn't mean these things aren't happening. And why not find them? Why not find the pre-diabetes, before you become diabetic? And you can be a diabetic and fly an airplane, but it's a heck of a lot more paperwork than it is for pre-diabetes, right? So then you're mad, oh, I gotta submit all these glucose. If you had just seen a primary, and gotten your lab work done and seen that, gosh, you're getting awfully close to this problem, let's get this under control. And I will say, for the most part, pilots are, especially as they get older, they're doing their calcium scores, they're getting blood work. They really want, I mean, some of them are getting whole body scans because they do want to know. Sometimes they're not getting it with their primary because they're like, well, I don't want it on the record, but I had it and it was great. And I'm like, okay, so now it's okay to be on the record. So I will say most pilots, especially ones coming in here, they do care and they are trying. But when I do see the ones that are checking the box for not haven't seen a primary in 3 years and they're like proud of it, well, it's because I'm healthy. I hope so. Like, I genuinely hope you are, but that is why just a routine annual wellness visit will help catch if there's something going on that just isn't overtly showing signs and symptoms. There are some very terrible things that do not rear their ugly head until they are stage 4: pancreatic cancer, ovarian cancer, colon cancer. So there's a reason, and granted, we don't have a lot of screening tests for those other two, but we do have screening tests for some of the big heavy hitters. So do it, do it. So
Well, this has been very informative, and it's
it's been
part
fun.
1. We are gonna meet
I know,
again
part one.
soon. Yeah, well, we're gonna talk about all things, like we said, mental health and SSRI next time, but that's for another day because this has been a lot and very, very helpful. I learned a lot. So thank you so much, Dr. Rachel
Yes.
Ferrero. And if how can our listeners reach out to you?
Yeah, so I you can reach out online. Probably my website is the easiest. It has the most information, but it's www.aviatemedical.com. So it's AVIATE medical.com. On there, you'll see my email, which is info@aviatemedical.com. Uh, I'm getting emails now. And the phone number for the clinic actually goes directly to my cell phone. I don't, that's probably not a good thing, but that's what I chose to do. I have 2 SIMs on one phone. So my office number, I'm an office of one. You were looking at her. So when you call the number or when you text, you're getting directly to me. And that phone number is 208-777-5282. I'm on Instagram. I'm on Facebook. It's at Aviate Medical. So there's lots of ways to get a hold of me. The website kind of gives you the biggest picture with frequently asked questions. I have some of my 99s articles directly linked on there. And I even have a pilot wellness page of some brands that I like for electrolyte replacement or, fitness apps and things like that. So I kind of think outside the box on the website. I also speak at shows. So I am speaking at Oshkosh, as I mentioned. I will be at the 99s National Convention in July in San Diego. If you're going and you're like, oh, I want to ask her a question, I will be there. I think I'm talking on the 9th about the flight physical. And I'll hopefully have a page up on my site soon about just other local events that I'll be doing. If anyone's local to Fairchild, I don't know if this is when this is airing, but I am going to be at the Fairchild Air Show this weekend. So I have a booth there.
So this weekend is the what's the date?
June 5th,
June 5th.
6th, 5th
6th.
and 6th.
5th and 6th.
Yes.
Okay. Yeah,
So,
I'll get this out soon so that
okay.
people can hear about it. And I know that this is highly anticipated. A lot of people said, when you do record, put a link here. So I will. Um, I'll get it all edited and ready to go for everybody.
Perfect. Well,
All
this was
right.
really
Well, thank
fun. I'm more than happy to do more of these. Education is so important in any industry, right? It's the foundation. And if somebody listening hears just one nugget from this and goes and does their screening test or feels empowered to do, to take better care of themselves, then this was all worth it, right? It was all worth it.
Well, I think you helped demystify AMEs.
Okay.
It is. No, it's true. We don't share too much. Be very careful what you do share. Be careful what you do. And there's this mystery to it. And you're obviously very approachable, very nice. We've talked. I look forward to keeping in touch with you. I actually have personal questions that I would like to ask you that not necessarily on a podcast, but I encourage everybody to reach out to you if they don't feel comfortable reaching out to their own AME, at least just to ask the question because
Right.
you're a very safe person to ask these questions to. So thank you so much.
Yes, of course. Of course.
Okay. All
Anytime.
right. All right.